Good. There we go.
Good. Is the light behind me bothering you?
Nope.
Okay.
No.
It's a little sunshine coming through the blinds.
So, boy, typically when I prepare, maybe I have half a page written. I definitely have a full page written and things written in the margins. And I'm not sure if I can read my writing. I've written so much.
That's
But
funny. Well, I'm glad we don't have a shortage of things to talk about.
I don't think so. I'm not sure if we'll get to an answer or not, but I think this will be a good exercise.
All right.
Should I jump right into it?
Sure. Let's go.
Okay. Hello, welcome to the Brandon Macco podcast. I have with me again Dr. Julie Siemers, and she holds a Doctor of Nursing practitioner degree. She's the author of Surviving Your Hospital Stay, a Nurse Educator's Guide to Staying Safe and Living to Tell About It. She also runs Lifebeat Solutions, which offers courses to healthcare professionals to make them better and save more lives. Thank you for joining me again.
Thank you for having me. It's a pleasure.
So what happened last time? And of course, you can click a link somewhere to find the last session. Is we talked about we're both trying to educate the public, and we're both trying to educate professionals. And we're trying to come a maybe two-pronged approach to fix healthcare as the best as we can to save lives, make lives better, because things aren't working as they should. And sadly, patients have to be advocates for themselves and have to know about their own conditions, right?
Yes, for sure. We
And
don't have an option today.
yeah, yeah. So I thought I invite her back because I'd love to sort of brainstorm and just talk back and forth, just about how can we fix healthcare, and what are the problems with healthcare, and can we fix them? Because you're an expert in sort of the inpatient setting, and I'm an expert sort of chronic pain outpatient setting, and maybe coming out from both avenues, we can come up with some ideas. And we're both passionate about actually helping patients.
Yes.
um, Maybe we could start with something we sort of talked about last time, is that the fire hose. It's just so much information, and I think, well, you mentioned nurses, that they just can't perform. It's just so much information, and they're just not performing. And I imagine for doctors aren't thinking of the top three diagnoses. They're thinking of the top one.
Yes.
They simplified everything down. Like, I was just thinking, you don't even need a fancy AI to replace a modern doctor. Just a simple algorithm would replace most of them, because they come out and they remember the basics of the basics for each condition. And so your idea with your courses is, I believe, is you're giving them sort of the key information they might have already seen before, but didn't, in one ear out the other. And this is like key stuff to save people's lives, right?
Yes, and my research, as I said back in 2009, understanding the term failure to rescue, which is the
Mm.
healthcare provider, and most of the time it's nurses because they spend 12 hours at the bedside, missing the signs of patient instability, clinical instability, or the beginning of deterioration. And it just really perplexed me that this wasn't, number one, in healthcare textbooks, it's not
Oh.
in the curriculum. And so teaching this to students for and healthcare professionals for over 15 years, I was able to distill down where are most of the problems occurring. And that's how I developed the courses. For example, neurological assessment.
Hmm.
If the nurses and healthcare professionals aren't tuned in to a change in mentation, then they're going to miss. Hey, why isn't the brain perfusing, with
Hmm.
oxygen and blood flow, et cetera? So that kind of developed the first 10 courses.
Yeah, I was trained. Well, my whole cohort was trained that at a minimum, even if there's no signs, you do like a quick neuro eval, and then if there's any neuroscience, you do a thorough neuro eval. In practice, it's no neuroscience, no neuro eval, some neuroscience, and you do a quick neuro eval. No one does a complete neuro eval.
And a lot of patients don't need a complete
Yeah.
one. But if the Glasgow Coma Scale, for example, changes by 1, 2 is a red flag. If they were alert and oriented and now they're confused to who they are, where they are, that's something to consider in why this change is occurring. What's going on?
And the thing is, and I didn't realize this until I did my specialty, or maybe it was presented to me and it didn't stick, was that a lot of the neuro exams and orthopedic exams have terrible accuracy rates. I think it's either the Babinski or it's the Hoffman that might have, was it 40% accuracy or sensitivity or something like that. Like it's low.
Hmm.
And doctors, okay, that's a test I do for that. That's a test for this. So I'll just do a quick one test. Okay, I've ruled that out. Well, 40% sensitivity, you haven't ruled out nothing.
Exactly.
But it feels like time is a big crunch, or at least in, again, outpatient setting. It's, oh, this person has nerve symptoms. Oh, I do 15-minute sessions. I only have 10 minutes. A full neuro screen is going to take me like 30 minutes. There's no way I can do it. So it's just
Right.
we've set ourselves up for failure with these quick, short sessions, I feel.
You're right. I think I've read two different studies. One that says the average time in an office that a physician is able to spend because they're booked tight,
Yeah.
per insurance and all those kinds of things. One study was 6 minutes and one was 16.
Yeah.
But even 16 is not an efficient amount of time or an effective amount of time, either way, to say what really is going on. And unfortunately, patients don't know the priority symptoms or, because a doctor can only spend so much time with you. And if you aren't understanding as a patient what to actually say and what the priorities are, it may get missed.
Hmm. And I was thinking as I was preparing for today's talk, I was often fighting with one of my bosses, like, I need more time with this person. I need more time. I need longer sessions for these types of patients, or they're just not going to get better. And he would retort back, my goodness, I get through 30 to 40 patients in a couple hours every morning. What's your problem?
I think obviously missing quite a bit, right? And as we talked about before, chronic disease is such a problem in at least America. We know that for sure. And multiple chronic diseases, because of lifestyle related choices, is really impacting the whole health of the patient and makes it very complex for providers to even be able to start to help these patients, especially as we talked about with a shortened timeline.
Yeah. So we have not enough time in the session per patient. We have some things missing in the education, and we have some things not sticking in the education, just some of the things we need to fix. So
Yes.
some of the things to fix. So one of the things that I've done for myself, and I'm also trying to make courses as well, and you're making courses, is we're trying to fix the missing information in the curriculum, or the bad information or old information in the curriculum, and we're refreshing them on the important things that the research is saying that people are missing, that they should have learned, but they didn't.
Yeah.
So
What's found in the literature too with nurses, and I'm sure other healthcare providers too, is the clinical judgment that is so essential to be able to not only recognize what's going on with the patient, but anticipate. Take, for example, a patient has COPD,
mhm,
chronic obstructive pulmonary disease. If they're post-operative and their oxygen saturations aren't doing great. I mean, I think what's burned in the brain of nurses is don't increase their oxygen. You could, cause them to maybe need to be intubated because they're going to lose their drive to breathe. But really, the priority, if a patient becomes hypoxic, you have to give them oxygen. Otherwise, the brain cells, the heart cells aren't going to get that life giving oxygen. So I think that's another point of re educating to, again, priorities. You've got to be able to think if this, then that. And that's where the challenge is.
sadly, some doctors think, oh, I don't want to do that test because if I do that test and it's positive, then I have to do this. I don't want to do that.
Oh my goodness.
But again, is that survival instinct because they're so time crunched?
A lot of it is. And the other part of that, I think, is they don't have the time to keep up on the latest research. I think
Mhm,
we touched on this last time. And so that's why I think it's so important for patients to take the proactive approach and learn as much as they can about their disease process, their medications, treatment options, et cetera, and then come prepared when you meet with your doctor.
mhm, mhm. And again, trying to hammer solutions. Already, there's mandatory continuing education requirements for all professions, basically, to maintain the license. Um, and I almost think that there should be, like, for example, the program I took, the 300 hours, I think that should be required. Like, yes, yeah, I think it should just be required. And you mean we should put that into the 3,000 hour program that you went through? No, 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 no. I think it should be spread out over the year because it takes a year of actually practicing. And the program was focused on communicating with other doctors. I think we had to write 100 fake letters on fake conditions to well, simulated cases to work on our communication skills. Like it takes time to develop clinical skills, and instead of that fire hose. So I don't want it. So almost like a an extended internship through practice, which is what's supposed to be a fellowship, but even beyond, but even in the fellowship, I think there needs to be, for example, standard online programs or more online programs. I think of Texas every single year requires me to do ethics and regulations every
Uh-huh.
single year. Every single year, 6 hours.
Interesting.
So that, and it ends up being really redundant, but
Hmm.
there's no doubt that it's starting to stick. And every 2 years, I have to do trafficking. And for sure, like you can't cover all of the rules and regulations in every single ethical issue in 6 hours. But the trafficking and the signs of trafficking, human trafficking, Texas is a real hotspot for that. The signs, I I've now taken every 2 years. I've taken it what 3 4 times. This course, I have the course memorized. So I feel like maybe with the important things, maybe we have to hammer things home 5 6 7 times. Specific programs, specific courses um, of the latest research, of the really important things, just to really, really, really make sure it sinks in.
Yeah, I fully agree. 2 points. One, it takes repetition to create neural nets in our
Mm-hmm.
brain, which is where the learning pathways occur. We've got to, fire those thoughts that wire together that create those neural pathways for learning. And the other piece that you brought up is application of knowledge. And so that does take time. There's a theory in nursing education, a nursing theory that is novice to expert. And it really is a timeline of what it takes, how much experience and time on the job that it takes to move out of the novice into competent. And it's about 2 years. And it takes 5 years to become an expert, but that's in one specialty.
Mm-hmm.
So if I worked ICU for a year and then OB for a year, and I wouldn't be expert, it would be 5 years in the ICU.
Mm-hmm.
Does that make sense?
Mm-hmm. It does. Um, and I think the curriculum also needs to change, particularly with centered around like it's really the curriculum has not kept up with research. It's really,
No.
really frustrating. And again, coming from my point of view, lifestyle medicine, we know diabetes is or type 2 diabetes is reversible and manageable. We know actually putting people on a plant-based diet helps with almost every chronic disease out to man, and there's no nutrition covered in most medical programs. None.
Yeah. Yeah, I think it's 80% is the latest statistic I heard of medical schools do not have any nutrition, not even one course. You're right.
And I think I might have mentioned in the last time, the medical specialty lifestyle medicine, which is trying to get traction for the past 10 years, it's just 40 hours. like again, maybe it's better to be presented after graduation. I think there is a benefit after you start practicing how, okay, how can I can implement that? But also, why didn't they see it at all in their program?
Yeah, I think when the curriculum is so pharmaceutical based,
Hmm.
it's difficult to, but so important to get in those points of start with the easy stuff before we start giving prescriptions. But again, we know what's backing,
Yeah.
the curriculums in medical school.
And of course, there is always going to be a lag or resistance because the teachers are teaching what they were taught or what they did.
Hmm.
And I always talk about tendonitis. There's almost no such thing as tendonitis. There can be tendonitis, but there's almost no such thing. The research is clear. It's tendinosis. It's a degenerative process. It's called mucoid degeneration. The increased blood flow is neovascularization. It's not an inflammatory process. The research is in 10 years ago. The
But
IC
nobody knows.
no nobody knows. People graduating today don't know. And it's not reflected in the CPT codes or the ICD-10 codes. Not tendinosis isn't there. So even
Right.
if you've learned it correctly, you go to, okay, I want to use the correct diagnosis to put this into my charts. Oh, if I do that, I won't get paid.
Right. You brought up a good point too. When I was in nursing school, we were taught adult onset diabetes and type 1, which is type 2, of
Yep.
course, as you said, and then type 1 is
Yep.
juvenile onset. Now the terminology can't be used anymore because children are getting lifestyle related diabetes that
Yeah.
we used to call adult onset type 2. It's not adult anymore. It's
Hmm.
now in the kids, unfortunately.
Hmm. And frankly, the management has to be changed early stage type 2 versus late stage type 2. There's different management protocols that should be followed. And of course, some doctors coming out of the old system, that's all the same. This is the
Yeah.
protocol for prescribing more and more because they'll only get worse under the protocol. They'll only get worse when you and I know they can. A lot of them can get better as long as the beta cells can
Yeah.
come back in the pancreas that produce insulin. As long as they can come back from dormancy, if there's some life left in them, you can come back
Hmm.
from type 2 diabetes. And it's just that's a really obvious thing we can pick on.
Yeah.
Um, so let's talk maybe about time again, because there's a lack of time, and maybe time. And now I'm going to try to tie that into what we were talking about. So lifestyle medicine, nutrition, sleep advice, positive social connections, all things to avoid depression, like exercise and things, like all things a doctor should be asking you about because it's all part of getting you better and keeping you healthy. There's another field, functional medicine, and you brought in up one of your favorite functional medicine practitioners. Although functional medicine sometimes gets a bad rap from a few practitioners which are a little bit uh, because the field attracts, I think, people who are trying to help, but not necessarily scientists. And part of functional medicine is trying to follow the latest research, trying to order the latest invented tests, and trying to use unusual treatments if the treatments thus far haven't worked. So it is about helping people and looking at all the functions of the body and how everything works together. Like, it's a good field, but if you have non-scientists, they might read one research paper and use the treatment from one research paper for one problem, and it doesn't fit together. And then one doctor writes a narrative or a research paper about it, basically a letter to the editor about how stupid this is and how idiotic these functional medicine providers are. So it's again, so hit or miss. I feel with some practitioners, they're trying their best. But I feel when functional medicine is at its best, it is just regular medicine, just with more time. When I did my own functional medicine
Right.
program, he said, yeah, you have to set aside a day, and that's going to be your functional medicine day. And you're going to spend 1 to 2 hours per patient you're not going to accept patients unless you have every single medical record, every single blood test that they've done, every single urine test that they've done. You don't let them sign up and book their first appointment unless this your office has everything and you've had time to go through it and you've written the 5 to 10 page report summarizing everything to try to figure out what's going on. That's and it's evidence based. You're checking the research, you're reading reports, you're doing tests. It's all evidence based when it's done right. That's just normal medicine.
Should be. Should be. I think the thing that I learned with functional medicine when I started looking into this, bio optimizing health, et cetera, was understanding that there's tests that a lot of, um, I'll just say regular physicians, with the typical practice
Yeah,
don't look at,
yeah,
which is heavy metals and
mm-hmm.
mold toxicity and
Yeah,
those kinds of things that can impact the health to such a degree. You can't fix it unless you eradicate
yeah.
those kinds of things if they're in the body.
And those are the people that have the chronic conditions that just don't get better.
Right.
And if you're listening and you're thinking, "Oh yeah, I have chronic problems," uh, be forewarned. It is a little expensive, and because you have to order these tests, and you'll sometimes people get angry when you order the tests when they're negative because it's why did I spend $1,000 from this test? Well, there's so many things it could be. We have to test to figure things out and rule things out. And I guess I have my I wear lots of hats, functional medicine hat and my neuromusculoskeletal medicine hat. So some people with pain all over and it's mental, or it's mostly mental, and they need more counseling. Some people with pain all over and it's neuromusculoskeletal. It's nerves, and some people it's diabetes, peripheral neuropathy. Other people it is more functional and it's thyroid. It's an iodine deficiency. And so there's so many things that it could be. And well, you can't give up, and you sometimes you have to go through lots of tests and different practitioners and different specialists to really get it, and it takes time. It takes time.
It does. It does. The body is amazing, but when it's broken, it could be, as you said, from many different things. I know Lyme disease can also cause
Oh,
a lot of the chronic problems. And most people that I've talked to with Lyme disease are basically told, it's kind of hopeless. But now I understand that stem cell therapy has been remarkably, um, um, what's the right word, successful
hmm.
in treating and eradicating Lyme disease.
And correct me if I'm wrong. I'm not in the States. I was in the Cayman Islands, and I actually worked at a clinic which did stem cells. And from what I heard, stem cells were last time I heard stem cells were still legal in the States. So if people wanted them, they were traveling to the Cayman Islands. They were traveling to Mexico. Is that still the case in the States? Do you know?
I think there is some allowance. I'm
Yeah,
not clear on
it
the
might just
particulars.
be
Yeah.
research studies still.
Yeah.
So if you're interested, if you like that idea, look for research studies. Or again, you don't have to be confined to the walls of the United States. You can go to the Cayman Islands. You can go to Mexico. You can go to Europe um, for these treatments. Okay. Now here I'm in Indonesia. If I wanted to talk to a doctor about something, I just open an app, click a button, a doctor pops up in a minute or two. I list up, message what are your symptoms? I break down my symptoms, and then I basically get back a list of drugs. And of course, me being me, I go and I check each drug. No, I'm not going to take that. No, I'm not going to take that. No, I'm not going to take that. But that's sort of what it's like. It's very quick, very efficient, and they're just following an algorithm. Okay, that symptom, I'll prescribe that. That symptom, I'll prescribe that. That symptom, I'll prescribe that. And I really do feel for a lot of, for example, urinary tract infections. Like how many women get urinary tract infections? They go in, they say burning pain, it happened after sex for the first time or new boyfriend or whatever, and it's like yes, UTI. Here's your prescription. Um, I almost feel like you could actually replace all like those interactions with AI. And I think AI could almost do a better job and could even think of the things. Okay, that combination of symptoms could be this, and could flag people, and um, and then send the doctors to then start to do hour-long sessions with the tricky patients.
Yeah, I think that's brilliant. I just got back from San Diego a couple days ago. I went to the Institute for Healthcare Improvement Patient Safety Congress in San Diego, and one of the talks was on AI.
Mm,
And I've got a list of articles that this doctor and team, research articles that have put out on the benefits, the efficiency, the effectiveness of utilizing AI in different aspects of healthcare. So I know a lot of people, when they hear the word AI, are really like hesitant or even like, oh no, I don't want to use that. But there has not been very much negative about AI. There's been loads more positive
yeah,
about the benefits of it. So yeah, I think it's brilliant.
yeah.
Like you said earlier, the doctors can't think of everything. They can't remember everything, and neither can nurses. But one of the most powerful things they can say is, I don't know,
Hmm. Hmm.
and have that humility to say, there's just so much information. Let's figure this out together.
Hmm. And I know some countries and sometimes there are things to because I'm trying to hammer out that time thing. There's just not enough time to do a good job. So get the AI to try to take some load off of the doctors or the professionals. And I know there's been other ways to try to take off that load, such as the there's more and more nurse practitioners, and
Mhm.
there's more and more nurses taking on roles that were more doctor related roles. And I'm thinking of in Ontario, this is maybe a decade ago now, they introduced, and I remember seeing commercials. Don't go to the ER, don't go to the clinic, call, let a nurse triage you over the phone. um, oh, poor Canada, poor Canada. And I'm thinking of time. You know, the Canada just doesn't have enough doctors, which doesn't make sense to me. But Canada doesn't have enough doctors, and it's not that the U.S. has, per capita. Oh, maybe the U.S. has 20% more doctors per capita. Maybe it's 50% more per capita. Maybe it's 100% more per capita. No, no, no. It's like 300% per capita more in the States.
Oh, wow.
Like
Had no
Canada
idea.
has a huge lack of doctors. Um, and I think people in the States, they don't realize that, like, if a doctor tells you to go get a test, you're like, okay, I'll just go to an imaging center and get that test and pay out of pocket or pay insurance. Maybe that's the headache. And maybe you have to go back and forth and get an extra visit because, oh, that doctor wasn't in network. I have to get this doctor to approve it. So maybe that will take time, but actually getting the test is no time at all. For example, I had a lump in a testicle. It's pretty big, like 2 centimeters. So could have been cancer. Could have been cancer. So sent down to imaging. I think it was February, and she said, okay, what what does March work for you? I was like, March, like next month? Yeah, yeah, that works great. I was surprised because I'm used to Canadian healthcare. It was March the next year, 13 months away.
Oh my gosh.
13 months away for a test to look for cancer.
Wow. You mentioned nurse practitioners. I want to touch on that for just a minute, just in the
Yeah,
US. Do they have those in Canada, by the way?
I don't remember.
Okay, that's all right. In the US, just so our audience listening, your audience listening, can understand, the practicum hours for a nurse practitioner is roughly 5 to 600 practicum hours. Another thing to understand is you don't have to have experience, clinical experience as a nurse before you apply. You just have
Mm.
to have a degree. So your
Ah.
bachelor's degree can get you into nurse practitioner school and get you a certificate. So the other part of in the US mid-level practitioners, which is nurse practitioner, is the physician assistant. Those are two very different requirements for schooling in the realm of clinical hours. My understanding is that physician's assistants typically have about 5,000 hours.
Mm.
So just as a bit of caution, if you
Mm-hmm.
are seeing a nurse practitioner, they could have 10 years in critical care and be amazing,
Mm-hmm.
or they could have zero experience except their 500 or 600 clinical hours and may not make the best decision. So, again, a really important reason why you, as a patient and family member, need to advocate and understand your health condition as best you can.
And I'm going to get to insurance and money because the insurance system, particularly in the States, um, it's not perfect.
That's being kind.
that, that's being absurd.
Yeah. Yes.
Because in a few ways, insurance dictating care, insurance dictating time per visit, because they're dictating reimbursement.
Yep.
And then even if you were to switch it to, let's say, outcome based reimbursement, so you get paid when the patient gets better. What happens if you have one of those super tricky cases? Once if some the doctor next to you gets 10 easy cases, you get one like super complicated case that takes you months to solve. Are you going to get 1/10 the pay? Um,
Yeah, it's healthcare became business back
mhm,
under the Reagan administration. And where it is today is really scary to me because, as you said, they are really dictating what is being approved to be reimbursed. I just learned of a lady who went into the hospital, the emergency department, who had shortness of breath. She had a history of pulmonary embolism. She was diagnosed and admitted to the hospital with a positive pulmonary embolism, got better, went home. Her insurance denied the hospitalization. I mean, it's really getting that ridiculous. And there also has been studies put out by reputable companies doing this research and news firms that there are AI implemented programs to automatically deny claims. And so you may not even have a doctor that has looked at it, or they may be under, you just got to crank these approvals or denials out so fast and they're rubber stamping. So I think a lot of people don't understand you've got to appeal and go through the process, as painful as it is, and use your voice and speak up because we've got to change that horrific practice, which, as you know, in the news, I mean, led to, the man being fed up with the insurance denials
yeah,
and unfortunately shooting the CEO back in
yeah.
December.
Like we need to, again. I'm thinking AI. Get rid of the like quick, easy visits and the just prescribing visits. Get those out of the way. And we need the doctor to be like the real family doctor again. The okay, like let me set aside the afternoon. Let me set aside the afternoon for you, Julie. How are you doing? Like learning about your family, learning about how you're sleeping, like the whole body experience, all the blood tests, keeping current, like really delving into things. We need like, and again, I'm tying this into insurance. I thought of this is that I think I was reading the other day that insurance will often deny. So when someone's had a pulmonary embolism and their body's probably full of thrombi, basically blood clots, insurance will often approve one scan, maybe the initial scan at the hospital, but might not approve a follow up scan and the subsequent follow up scan and the subsequent follow up scan. So if you want to check to make sure there's the blood thinners have worked, that there's no more blood clots, you're not going to get paid for that. Which
That is crazy. That is honestly crazy. We cannot treat patients and cure them, get them better, put them on the path of health without the ability to do those things, as you and I know are appropriate and really necessary.
mm-hmm. So I wonder about the public option. And of course, I come from Canada. I've suffered through the Canadian system, but I know more about the US system from working in the US system. Um, but there are downsides to the public system, and for my audience, which I think is mostly American. Actually, there's a lot of Europeans and Asians in my audience. Um, so in the Canadian system, it is public. There are some private options, but the government often fights it, and sometimes there's protests. No two-tier healthcare, no two-tier healthcare, no healthcare for the rich. In my mind, get the rich into it. Get the rich out of the public system so there's more room for everyone else, in my mind. But there are limited. I didn't even know there were private options. Like I could not. I couldn't do stairs, and I couldn't cycle after getting hit by a car, and I couldn't get an MRI on my knee. And it wasn't urgent enough. Why? Because it doesn't matter if we fix your knee or not. There's an elevator at your workplace,
Oh, wow.
and you can walk. That's fine. You can walk. You don't need an MRI. You can walk. Uh, I didn't realize that there's private clinics in the big cities. And when I was in a small town, no one said that there were private options, and there weren't. I would have needed to go to the big cities. And I just called up one of the private clinics. Yeah, how's this afternoon? Okay. And again, normally it's a 3 to 16 month wait for anything in the public system. And so there is a small private option, but because it has the public competition, so I could get this now, or I could get free later. Or if I fight more and go to more hospitals and ask them, I could do it free, which keeps costs down. Do you know how much an MRI was? Now, this was a decade ago, but do you know how much an MRI was? Like
No,
500 US.
that to me would be worth it.
Yeah, that's worth it, and that's a reasonable price. It is not 500 US if you want to pay cash in the States.
No, it's horrific. Yeah, it
It's
truly is.
thousands. It depends hospital to hospital. But I think having the public option keeps costs down if you have a two-tiered system. So I sort of like the idea of a
Yeah,
two-tiered system.
I agree. I think a lot of expats leave the US because of the cost of healthcare. I know there's places that you can go that you don't pay insurance. You just pay as you go as you need it. But a physician's visit for, let's say, a UTI, like we talked about before, and the urinalysis and the medication is 25 bucks
Yeah,
US. I can do that all day long.
yeah.
Well,
And one of the reasons why it's expensive in the States is, well, there's lots of suing going on in the States because there's lots of medical malpractice, in part because doctors don't have enough time in the training. And but oh boy, it's the paperwork. The paperwork. It is so onerous.
hmm
If you look in the States and look at Wikipedia, you pick a city, and it'll typically say, what are the industries, big industries in the city. I was shopping what city I wanted to live in when I was, well, before I moved to Texas and opened my clinic. And in almost every city in the States, it's health insurance company, health insurance company, health insurance company. One, two, three. In every city I looked at, it was like that. In Canada, it's like a university, a mining company, or a forestry company. Like it's a variety of things. Typically, education is top. But so why is the state? So it's such a big business. I realize because Trump had an interview, I think with like Barbara Walters or something. It was 60 Minutes or I think, and he said I'd like to make public healthcare for all because he looked at the Canadian system. Oh, it's so much cheaper. It's so much cheaper. The U.S. pays more. The U.S. currently, with its current system, the government pays more per capita than Canadians per capita.
Yeah, I read an article a couple months ago that the US was out of the developed countries, the US was number 10 out of 10 in healthcare quality.
Yeah.
But we spend 3 to 4 times as much as any other country on healthcare, but yet we're ranking the lowest.
Yeah.
And our deaths are occurring earlier.
Yeah.
So we're not doing something right.
No. And that might be including the private insurance plus government. But I couldn't believe the government is actually spending so much Medicaid, Medicare, and also supplementing insurance companies. If you actually read the like 1,000 pages of Obamacare, part of it was just like a gift to the insurance companies. Okay, you have to implement these things, but in exchange for us forcing you to implement these things, we're going to give you millions and billions of dollars every year. So not only are you paying these huge premiums, but they were getting huge amounts of money from the government. These, I guess, kickbacks probably. There's probably lobbyists involved in negotiating those deals if you actually read through the pages. But I was thinking, so when Trump's in office, he's like, it's a lot. I forget exactly what he says. It's a lot more complex. I can't do what I wanted. I think if he instituted some sort of public system, like truly public system, that it would crash the economy because
Maybe.
there's so much because the paperwork for every doctor you almost need one person hired just for the paperwork. Maybe one person full time could do two doctors. But even the doctor, we already talked about how time crunched they are. They spend, I forget what the statistic is. It's more than 25% of the time. 25% of the time working on compliance for insurance.
Yeah, and nurses in the hospital say they spend about 50% of their time documenting in the chart.
So imagine how much more time they would all have if they knew they would just be paid. They just have to, they're charting not to be paid and not trying to figure out codes to be paid, but charting for themselves so they know what they did next time, or for whoever's going to take over the night shift. They're charting for patient care, not for the insurance company. And they're not worried about, imagine if doctors were maybe salaried instead of, working on code.
Yeah, like
Um,
they are in the UK,
yeah.
correct?
This Medicaid for all or Medicare for all, Medicare, if you from the doctor's perspective, is terrible. They
For
will ask
reimbursements.
for the reimbursements are terrible. They will ask for your notes. They will deny everything. They won't cover a lot of procedures. And they pay terribly for most things too. So and if you make a mistake, they'll fine you like $10,000 for fraud
Oh my gosh.
per incidence.
It's a little nutty.
Yeah, so you don't even want, so Medicaid for all or Medicare for all sounds like a nightmare, and it sounds like a paperwork nightmare, and would just take so much time. Um, so even though I love having a public option, I'm not sure if just expanding Medicare for everyone would work.
Yeah, I don't know. I haven't researched that enough. I think, my small niche of patient safety keeps me very busy.
Yeah, yeah, we're delving definitely out into unexplored territory.
Yeah,
I'd be surprised if anyone had a confident answer to the questions we're posing.
true.
Um,
True. It's
but
nice to put them out there, though, to get people thinking, right?
yeah, because if we don't think about them, then we can't start debating and talking and maybe thinking about
And solving.
solving these things. It can't be,
Yeah.
oh, it's too complex. We're not going to touch it because it's too complex. It's the sacred cow. We can't touch it. Well, maybe we have to touch it.
For things to change, I truly believe that we've got to just pull back what I call the Wizard of Oz curtain of healthcare. We need transparency. We
Hmm.
need accountability before we're ever going to be able to move the needle. And it's interesting, this week was Patient Safety Awareness Week in the US, and that was the theme for 2025, this move the needle. And at the Patient Safety Congress, the theme was action. We've talked about it for years. The To Err is Human report came out in 1999. It had its 25-year anniversary last year. We're not any closer to eradicating patient harm than we ever have been. And we really do need to take action. So
Hmm.
that's what we need to figure out.
I was interviewing someone just last week, and she said, um, she was worried because the government currently is cutting all this funding for research and all these programs, and I'm like, if like, what happens if they destroy the healthcare system? What happens if that ends up being a positive? If we almost need we need a reset. because it's sort of stuck in its ways.
Yeah, it truly is. Like you mentioned before, just because we've always done something a certain way doesn't mean it's beneficial or the right way to do it today.
And we need to take a hard look at how we do things. So I think that's actually a perfect summary of what we've been doing for the past 45 minutes. Do you have any closing remarks?
No, other than I just am very hopeful. I think I said this at the close of last time, but I really want to reiterate that because a lot of what we talk about, it seems like so gloom and doom and hopeless, but I really believe getting engaged in your own health to start with, and your families, etc., is the first step that you can take, and then spreading that message out to others. That's in your tight knit close circles, and then your communities. That we really can make a difference by speaking up, finding your voice, getting informed and educated, and it really can make a difference. I truly believe that.
And not for us making money, but to help you guys, I am going to plug our books. Right? Your book was Surviving Your Hospital Stay, and my book is Pain is Not a Life Sentence, more on neuromusculoskeletal pain. And they're about self-educating, and you have to not give up and use the healthcare system and communicate with the healthcare providers. You become an expert in you. They're an expert in their specialty, and you consult on the problem. Sadly, and in a way, you are the only expert. You're the only one who can feel what you feel. And if you're dealing, family, your family's only experts in how you normally behave in day to day. For example, we talked, I think, about deliria, or basically not being yourself is often a sign of an infection or something seriously going wrong. And so listening for those signs and knowing those signs is sort of the key. So we wish everyone out there the best. We didn't really talk about the drugs and the perverse incentives with the pharmacy, and
Right.
the concept that people dying because they can't afford care, or they're scared to afford care. And we didn't really talk about that.
Yeah, that's a big issue. I just learned recently about the pharmacy benefit managers that are hired by insurance companies, but they're a part of the insurance company that are supposed to negotiate better pricing on medications. But for some reason in the US, we pay about 10 times for the same drug as other countries. And I just learned about a story not too long ago. I think it was about in January. A 22-year-old went to his pharmacy to pick up his asthma inhaler, which typically was $66 out of pocket. And today the price went up to $569, which this poor kid couldn't afford. He tried to survive on his rescue inhaler for the next couple of days and got so extreme with an exacerbation of an asthma attack, and he died.
Mm-hmm.
And his parents are suing Walgreens Pharmacy as well as the pharmacy benefit manager, because it's the profits that these companies are making off of the backs of healthcare, at least in America, is just egregious. And to me, it's criminal. I think there was a report that they made over $7 billion in profit over the last 3 or 4 years. And of course, that's coming out of our livelihoods. When someone can't afford care, what are their options?
Mm-hmm.
Because they don't get the medicine, they don't get the care. I mean, patients coming into the ER in the US for hypertension because they couldn't afford their drugs and now they've had a stroke. That's been going on for a while, but I think it's getting worse.
Yeah, and and the drug companies, of course, coming up with new and new drugs. They, even if it does the same or worse than the old drug, but that's the drug that gets pushed because that's the one with the patents. So that's the one they can charge the most money on, and that's when they push. They run the advertisements for, and of course the protocols. It's tricky to figure out whether it's a time crunch thing or whether it's just this is the way it's always been done. But just the emphasis on pharmaceuticals, it is to against research.
Right. It really is. And it's
And
just, I think it's over the last decades has definitely escalated to be more harmful to all of us.
Yep. And getting this, actually, it blew my mind the other day. Because in Indonesia, my wife didn't tell me, but apparently she had a toothache basically for half a week without telling me. I look in her mouth. It's swollen, inflamed. I touch on it. It's all gummy. It's like, yeah, that's an infection. Um, I just walked across the street and I asked if I could have some antibiotics, and you don't need a prescription. I just went and I asked, and it was, oh, what was it? It was like $1, $2.
Wow.
Because they're a lot of the drugs, particularly the generic drugs, they're not expensive anymore. They're so dirt cheap outside of the states. Imagine going to go get your pills, and every time you go get pills, it's, pharmacists are more expensive in the states because they have a doctor of pharmacology degree. I don't know, maybe it'll be $10, $20, but that's how much it should be. And also, just so it's not just the drugs that people die; it's people refusing to get into an ambulance because of the cost. Some like, yeah, I think you're having a heart attack. No, don't call an ambulance. Don't call an ambulance.
I can't afford it.
Yeah,
I'll go
yeah,
bankrupt.
yeah. Insurance companies themselves, they have done the studies to save money because they often own the hospitals, right? They actually do want people to come in. That's why they sort of they experiment with copays and things. They want like a small copay so that people will come in, but not for something trivial. Uh, some skin in the game, because it does save the money in the long run to catch things early.
Right.
But
It's
we need to also have that thought. But if you have an insurance plan which is a super high deductible, and you go into a doctor, and doctors don't. This also drives me crazy in the States. When I was in school, they told us never post your prices. If someone calls and asks you your prices, don't tell them your prices. You only show prices afterwards. You don't ask them and tell them how much something's going to be until you give them the bill at the end. That's the way things are done. But people have such a panic and these super high deductibles. It's going to be $1,000 if I see the doctor, and they're going to order these tests. And no, I'm just not going to go. I'm not going to go. I'm not going to go because they're always scared of the $1,000 bill, um, and that kills people.
You're right. Delaying, and you don't know until you do get some diagnostic exam, some
Yeah,
lab work or a
yeah.
CT scan or whatever. You don't know, and you could be gambling with your life. And I really feel so much compassion for these patients that are trying to determine, is this serious enough that I go to the hospital or should I just try to wait it out?
Hmm.
It's not a good place to be.
Yeah, it's tricky. So thank you so much for joining me.
Thank you for having me. I appreciate it.
Cheers.